Dear friends, I'm Dr. P. Bose. I'm the founder of SANS Foundations. I'm a senior consultant pulmonologist, actively involved in the specialty for more than 2 decades. I work for a couple of corporate and hospitals like National Heart Fortis. And in my experience in last more than 2 decades, I've seen that this specialty needs a very holistic approach. It needs trained professionals, a collective team, better understanding of this specialty. Now, what we are going to discuss is that how the SANS Foundation thought of, conceptualizing a concept where the pulmonology can be taken in a better way from yesterday years to modern years and taking forward in the future years. So my talk on today will be the pulmonology yesterday, today, and tomorrow. When we have been working actively in SANS Foundation with our different, community outreach initiatives, what we call like that, we have different forums. Like we used to reach out to the people through our activities called Sarthak, which was one of our flagship program. We used to skill people through our program called Saksham. We used to skill therapists and train nurses so that they understand pulmonology and cater to better, patient care management. Or we have this very high tech therapist who we are trained to the next level to take care of the pulmonary rehabilitation through our Samarth initiatives, or even the continuity in care, what we call the home care with our Sahaj initiative. The SANS has been progressively very smoothly, and in no time we could catapult a very smooth symphony in the patient care system. In that process, we came across a great friend and visionary, our fourth pharmaceutical from southern part of India. So we decided why not we take the pulmonology to the next level, because this demanded that the specialty demanded a lot of training, a lot of right dissemination of knowledge, because the right dissemination of knowledge was not very, you can say very systematic in different parts of India. It was very, regional centric and very sporadic. So clinics in chest medicine in India was a concept which was decided, and we established a forum in 2019, Clinics in Chest Medicine India, with Force India Pharmaceuticals, with their visionary, and SANS Foundation and the Force India Pharmaceuticals are working together to create this forum, this Clinics in Chest Medicine, to different initiatives through digital platform, through hands-on experiences, through conferences, through reach out activities, through different certificate courses, and so that they can collect the young pulmonologists to the next level. So at CICM, we are really working very hard. So how best we can, take pulmonology to the next levels. So friends, so you have to understand why there was a necessity. The necessity was like that, if you go back about 20 years back, the pulmonology was very basic, mostly were tuberculosis hospitals. The good people were not coming to this specialty because there was a lot of stigma attached to this specialty, because tuberculosis, and usually the disease, the specialty used to be called the MD in tuberculosis and chest diseases. So more emphasis was given on tuberculosis. I understand there's a need of the hour. India is the tuberculosis capital of the world, but that was not enough, because when you talk of a specialty, when you're treating only one as an organ, and that too as an individual organ, that doesn't take care of the purpose. Because if you see lung as an organ, I think this is an hub of the body. It's just like something like an hub and spoke. If one has to understand the respiratory system, one has to understand the whole human system, because this is the hub and this is the spoke, because the lung is connected to the different organs, and whichever the disease you talk today, they are like a syndrome. They are not very lung specific. They are much more extrapulmonary than pulmonary. So it was thought of that it's very important that the people should work, the professionals, the modern professional people who got trained nationally and internationally, we should work together to take this pulmonology to the next level, so that we have a better understanding of the respiratory system. And then, of course, the COVID taught us the lesson when we found that pulmonology became the brunt of the main whole process of this epidemic. So since 2019, we launched a very big conference in Delhi. It was attended by the best of the pulmonologists in India, and it was a consensus that we have to take the pulmonology cohesively and collectively to the next level. And the best of the pulmonologists from India that participated, they consented, a couple of books was released. And we thought that probably the best way to reach out to the people is not only a conference, we have to do small activities, the hand-on workshops, reach out programs, patient-centric programs. And in that process, a lot of manuals were released. So one of the interesting manuals which was released in the initial conference, which was held in the month of October in 2019 in Delhi, this was a manual of chest disease was launched, which was made very simple for the professionals so that based on images and algorithm, they can understand the key points of the diseases. So the CICM's vision was to take the pulmonology to the next level by collecting all the dots. And its mission was that, the next level pulmonologists, because the decade of pulmonology belongs to the next generation, so that they are much more aware, they are much more connected, so that the right kind of dissemination of knowledge is possible through only when we take this specialty as a super specialty and think more from a holistic point of view. Like for example, I'll quote an example. When you talk of COPD, probably it is numero killer in the worldwide. If you see that it's slowly taking the numero position because of the tobacco and climatic changes and industrial hazards. COPD is not a lung disease in true sense. It's not focused only in the lung, though it's a disease of the lung primarily because it affects the lung and the alveoli, or what you call the elastic properties of the lung. But when you have an advanced COPD, it goes beyond the lungs. So that's why you call the COPD as a syndrome. It affects your mental health, it affects your emotional health, it affects your muscles, it affects your nutrition, it makes you very, sedentary, you go into kind of deconditioning. And that's why, when we treat a COPD, if you only treat the lung, you don't get the results. So that was required. And most of the institutions, we are talking only about the lung and respiratory system. So it was realized that when you pick up, like for example, we talk about COPD, we have to go beyond molecules. We have to talk as a holistic. We have to involve different specialty people who can take care of. Like for example, like when I talk of beyond molecules, that means you have to talk of bronchodilators and antibiotics and vaccination, much beyond that. Now, what is beyond that? That means you have to talk of breathing techniques, you have to talk of motivational techniques, you have to talk of nutritional techniques, you have to talk about oxygenation system, you have to talk about certain mechanics of lung, ventilations, what you call non-invasive ventilations. There's so many things, and alone a pulmonologist cannot take care of it. So when you talk of pulmonology as a super specialty, it is very multitasking. It is multi-speciality. It involves different cohorts of professionals who are working at different levels. So that gives the birth of what is called pulmonology. Now, when we talk of pulmonology today, it's no longer a yesterday pulmonology or tuberculosis. We talk of respiratory, we talk of allergy, we talk of tuberculosis, we talk of ventilation, we talk of non-invasive ventilation, we talk of sleep disorder medicine, snoring and related diseases. We talk of rehabilitation, we talk of home care. So you can imagine this is perhaps the one specialty which talks of the whole human system. So how is it possible that a person with 6 years of training as an undergraduate gets into a specialty and gets trained? It's not possible. So in yesterday years, the specialty used to be called the master's or diploma in tuberculosis and chest disease. That was not enough, and we were not getting good people also, because these youngsters were not motivated also to do this, because when you only talk of tuberculosis, you have basic disease and very stigma, and the environment is very, very negative. So people were not getting motivated. Then people realized that, pulmonology involves a lot of things. It involves good ICUs, good ventilation techniques, the communications, end of the life issues, allergic techniques, modern antibiotics, different things, rehabilitation, understanding blood gases. So they understood that this is not that simply you after undergraduation you get into a course and do 2-3 years is not enough. So that gave the birth of what you call super specialty pulmonology. It's there for the last 15 or 20 years, ever since we are probably one of the pioneers and initial people. We have got into the super specialty because myself as an internal medicine, so I'm not a pulmonologist and an MD pulmonology, I'm an MD internal medicine. We thought probably When you do internal medicine, which is a very difficult area, when you understand the human body as a holistic point of view, when you read neurology, when you read gastroenterology, when you talk of endocrinology, when you talk of skeletal system, when you talk of human system as a whole, then only you can catapult your understanding to the go to the next level, what you call pulmonology. So I think today's pulmonology belongs to people who have done internal medicine. They are the people, they should go to the next level as a pulmonologist, because unless and until you understand the human body as a holistic point of view, from mind to toe, from every organ, their mechanism, the physiological function, the pathological impact, you will not able to cater to the needs of the patient. Because most of the diseases, whether you talk of chronic obstructive pulmonary disease, whether you talk of lung fibrosis, whether you talk of post-COVID lung fibrosis, whether you talk of allergic disorders, whether you talk of any pneumonia, pleural diseases, or sleep apnea, or any kind of respiratory failure, this is not lung-centric, it is much more beyond lungs. So that's why most of the chronic lung diseases are more of a syndrome. So we have to understand the human body. So it's a very difficult specialty. Unless and until organized platform like CICM or equivalent bodies don't get into it, this kind of partnership programs, our youngsters who are aspiring to become a good pulmonologist, they will not get the opportunity and a hands-on experience to practice the right kind of specialty. Most of the medical colleges may not be adequately enough to take care of this, because the facilities, the government hospitals, or whatever may be the limitations. So we find even the youngsters who are coming into pulmonology, seeing the fancy thing that probably post-COVID they can enhance their practice. I understand the pulmonology as a physician is very exciting. It's very glorified. A lot of people are asking for pulmonologists. People Google about pulmonologists, and it's like it's no longer like it's sitting in one corner. It's probably as important as cardiology, maybe more important. But you have to be skilled enough. You have to be knowledgeable enough to cater to the needs of the people. And that is whole thing about clinics in chest medicine. Basically, clinics in chest medicine is working passionately to connect all the dots, right from the community to the training, the support people, to the therapists, to the doctors, and everything, so that right understanding of the patient and that treating the disease as a whole. What we talk in CICM, don't treat the disease as a simple hole in the body, HOLE. Treat the disease as a whole, WHOLE. That means you have to be very holistic. You have to understand the disease much beyond than an organ. And that's why it is a decade of treating, these chronic respiratory debilitating conditions going beyond molecules. So today's pulmonology demands a lot of good people, a lot of energetic professionals, a lot of support specialty like therapists, psychologists, nursing attendants, good nurses, intensivists, physicians, different people, and they can all work as a team. And that is what this CICM is striving to achieve that. So today's pulmonology, definitely I could see in the last decade or so, has definitely gone leaps and bounds. Now pulmonology as a specialty is accepted. You go to any hospitals, most of the hospitals are with good ICUs. Whether you talk of high-end ICUs or high-density ICUs, you will find the pulmonologists active. But what I could see that even in today, despite the fact there is an emergence of good pulmonologists and good knowledge base, but still pulmonology is still the backseated, because we don't find good professionals. We don't find, still the prescriptions are not very up to date. Still we don't find, people don't talk about tobacco cessation. Still we don't find people are talking about pulmonary rehabilitation. Even if they are talking of pulmonary rehabilitation, they don't know whom to refer for pulmonary rehabilitation. So there are a lot of missing links in pulmonology. So today's pulmonology needs a lot of effort. Today's pulmonology needs people who cater to all kinds of respiratory care practices. Whether you talk of the basic physicians, to pulmonologists, to therapists, to wellness experts, to certain allied care professions, they need to be brought together and given certain structured, cohort-based, certification, so that they can work together. Like for example, when you talk of COPD. Now COPD, as we know, it's a chronic obstructive pulmonary disease where the lung goes into a lot of elastic changes, and the drugs have very little role to play when it goes to a very advanced level, when you have lots of elasticity, what you call emphysema. Patient is having low oxygenation and high carbon dioxide. What do? You treat them at hospital, give them antibiotics, give them steroids, give them bronchodilators. Okay, it's fine. But that is not enough. There has to be a continuity in care. And who will do this continuity in care? A doctor cannot go and do the continuity care. So this continuation is only possible when you train people. And this can create a lot of livelihood to people also. And who these people can be trained? A good therapist can be trained. A good nurse can be trained. So we need a lot of nurse practitioners. We need a lot of therapists who are specialized in lung care programs. And that's why you see the whole world, the society is becoming geriatric. The population is increasing, the morbidity is increasing, the chronic care practice is becoming a very need of the hour. So chronic care practice cannot be done in your outpatient clinics or in hospitals. So it is something like what we call womb to tomb. So you have to take care from the day you're born till you die. So somebody has to take care of this continuity. So there's a lot of ownership in pulmonology practice. The people who have understood this specialty are doing it more systematically, organized. An organization like CICM, which we thought of. So our whole aim is to identify the good pulmonologists who have been practicing with a lot of earnest and dedications. Why not we club them at a different regional level and take to the next level and train different support people so that continuity in care is possible. The right dissemination knowledge is possible. And I always say that when you want to give a good care of your specialty, and when you claim yourself as super specialty, then you have to be very preventive. You have to be very you have to talk of beyond molecules. You have to talk of chronic care. You have to talk about synergy. You have to talk about understanding the disease from philosophical and psychological point of view, because disease is not only a bundle of organs and discomfort. When you're continuously huffing and puffing, whether it's a lung fibrosis or whether it's a pleural thickening or is a post-tubercular destruction of lungs or COPD or a post-COVID, imagine when you're breathing, huffing and puffing, when your respiratory rose huff, only thing which you can think is that my life is a hell. So you can imagine the kind of emotional health, the kind of mental health, the turmoil they go through. So we need people to educate who can communicate well, who can create an empathy. So this is decade in pulmonology where we have to create more empathizing people. And that's why our tagline is that have empathy, not sympathy. So this is the very important. So in today's we have to, and CICM has decided to take on this program much more effectively, much more structured way. And podcast is one of the way to sensitize a good pulmonologist, because when this program we reach in more and more people, the youngsters and pulmonologists who are aspiring to go to pulmonologists, actually they can chip in, give their ideas, and probably we can disseminate knowledge at a different level. Because as we say, the CICM is basically what you call digital to podium. Like for example, digital is a way of connecting people, but whosoever wants to do some program, we are there to support it. So at CICM, what we have decided that different regional level we will be having this different kind of activities. Already in the COVID time, we have done a lot of community outreach activities. The Fight COVID was one of the brilliant initiatives which the CICM did. Then recently CICM, to connect all the doctors across the nation, the Healers Award was given. It was basically given to pamper and to motivate and also to recognize the doctors who have worked tirelessly during COVID time. So I think thousands of Healers Award has been given by this forum, and it was an amazing thought process. So like this, through these small connections, we can try, if we can rope in this good pulmonologist, I think our today's pulmonology can go have. Now coming to the next level pulmonology, when we talk of, we spoke about years, now we are talking about holistic pulmonology, disease as a whole in today's pulmonology. Now what is the next level pulmonology? What is the future pulmonology? Future pulmonology is all about predictions, all about preventions, all about participatory, all about personalized. That's why the future pulmonology is about 4 P's. It is preventive, it is personalized, it is participatory, and it is predictive. So we have to predict. And now we have AI coming, artificial intelligence coming, the digital platforms are coming, interdisciplinary are coming, the biological scientists are coming, the data scientists are coming. With the variables, we can predict who will go for a COPD, who will not go for a COPD, who will go for a bad COPD, who will have a stable. So predictive science is coming in a big way. If you see, look around, the data science is coming in a big way. The algorithms and most of the ventilation we are using today, the non-invasive, they're algorithm based. So I think the future pulmonology will be a combination of an expertise, knowledge base, dissemination of knowledge, understanding disease, and also taking care of the 4 P's which I told about. It has to be predictive. You should predict who will go worse. And you should be preventive. We have to talk about certain preventive measures, the tobacco cessation, the vaccinations. It has to be participatory. The pharmaceutical has to work with the doctors. The other support bodies have to work together. The social sectors have to work. The climatic people have to work together. The weather is also playing it. It has to be. And of course, as we say, the one code doesn't fit all. So you cannot say that one drug will fit all. So it has to be very personalized. Every asthma is different. Maybe genotypically they are asthmatics, but phenotypically all asthmatics are different. Some may have an overlap of COPD, others may be a smoker asthma, there may be an obesity-induced asthma. So now we are talking about genotypes and phenotypes. So it has to be very personalized. So dear friends, we have a lot of responsibilities, a lot of ownerships. If you're a pulmonologist aspiring to become a better pulmonologist, if you want to disseminate knowledge, if you want to bring change, and I always say, there are two ways of understanding the life. One is that either you become an ice cream that you enjoy till it melts, that is for yours, or you be like a candle. You melt and you spread your good light around. So if you want to be a candle, join us, be with CICM, we'll spread the good work. Thank you. Have a great day. Regards, Dr. Bose.